All right. Nobody's answering.
Okay, sir.
Okay, right. Right. So what is teenage pregnancy? Anybody? What is teenage pregnancy?
Pregnancy of a girl less than 18 years of age.
Yeah, less than 18. Pregnancy occurring in a less than 18-year-old girl, right? Okay. So when they are closer to 18, they are more like adults. But when they are 13, 14, 15, or 16, the risk is high. Okay. So we'll be discussing the problems mainly to the younger, the teenagers, 16, 17, 14, right? They are the people who have more high risk problems, right? What are the causes? Can you elaborate some of the causes for teenage pregnancies?
Lack of education.
Okay. Poor education. Okay. Leaving school
Contraceptive.
earlier. Yeah. Contraception.
Rape or incest.
What did you say about contraception? Can you tell again?
Availability and knowledge about contraception.
Yes, poor knowledge about contraception is one thing, and access. If they don't have access to contraception or non-availability, rather than it is available, it's mainly the excess. It is available. It should be made available, accessible for the teenagers to get it, right? So the knowledge about the contraception is important, as well as it should be accessible for the teenagers. There should be a setup where they can get their contraceptives without any social embarrassment. Any other things?
Early marriage.
Early marriage, yes.
Low socioeconomic status and the poverty.
Yes, that is one of the main, the main culprit in not only in all part of the world, the poverty and low socio-economic status, because that will contribute to all the other things we have. That will contribute to the lack of education, early marriage, and no knowledge about the contraception, right? Okay, so that is one of the main reason in our country, the low socio-economic status and poverty. Anything else? Rape, yeah, okay. Rape and incest. Do you know what is incest? What is incest?
Incest is when a family member or direct blood relative is going to do sexual intercourse.
Yeah, close blood relative having sexual intercourse. It's also a kind of rape, but the child is unaware, so she has been raped by a close family member, right? Okay. What else? The other thing is, it's not related to our country, but if there is no service of or legalized service of termination of pregnancies. So in most of the Western countries, they offer termination of pregnancies for teenagers or any unwanted pregnancies. But in our country, it is not legal. So they have to continue, most of them have to continue the pregnancy unless two specialists, right, feel that it is dangerous to continue the pregnancy for her life, the child's life. So usually in our setup, we have a psychiatrist opinion as well as a gynecologist opinion. If both of them feel this pregnancy is continuing the pregnancy will be dangerous for the girl's life, then we can terminate legally. But otherwise, we don't have a setup like that. But in most Western countries, they have that, right? So these are the most of the the causes or the background for us to have teenage pregnancies. So teenage pregnancies are high risk category, so we call it a high risk pregnancy. Okay. So today we will be discussing the salient problems in the antenatal period, during labor, and postnatal problems. So if that is how you have to answer any questions if regarding pregnancy, a condition in pregnancy. So you have to classify or divide them into antenatal related problem, intrapartum problems, and postnatal problems. Okay. So if a girl is pregnant less than 18 years or teenage pregnancy, what are the antenatal problems we can expect? When we take antenatal problem also, you can divide that into first trimester problem, second trimester problem, and third trimester problems. Okay. Right. You can answer now. Right. What are the antenatal complications or problems we may expect? Are you with me?
So,
yeah, miscarriage. One person said miscarriage, correct. So that is a first trimester problem. So most teenagers have teenage pregnancies are prone to have miscarriage because of they are not physically well grown to continue the pregnancy. So the fetus may miscarry early on. They are from a lot of teenage pregnancies are from poor socio-economic background, so they are not nutritionally and psychologically not well established, so the miscarriage risk is high. Okay, next one. Anything else?
Social embarrassment may lead to psychological problems.
Yes, psychological problems, that is relevant for whole 3 trimesters, first trimester, second trimester, and third trimester. So psychological problem, or that can lead to psychiatric problems, suicidal tendencies. Okay, yes.
Nutritional anemia.
Nutritional anemia. So nutritional anemia, as I said, that is because of their background and they are not physically grown yet. So the demand is high when there is a growing fetus inside. So they are nutritionally depleted. They may not be taking supplements also because they may be hiding the pregnancy. For some of them may be hiding the pregnancies till during late second trimester. So we see a lot of pregnancies like that. The mother bringing at 28 weeks or 38 weeks. So all antenatal care is lost and no supplements, no nutrition. So they are prone to get nutritional anemia and other nutritional problems. What else? Yes, that is also high risk problem. Yes, correct. What else? Are they prone to get other problems like hyperemesis? Do they have any added risk of getting hyperemesis? Yes or no? Anybody? Yeah. But in realistically, it is not. Okay, they are not of high risk. Okay, anything else they are at high risk in the first trimester? Miscarriages, correct. Anything else? Gestational trophoblastic tumor, the identiform mole, it has a bimodal distribution, no? Advanced age or very young, right? Do you understand? So the risk of gestational trophoblastic tumor is high. Okay. Anything else?
Having ectopics.
Ectopics. Why? Can you give reasons? Can you give reasons? Is your guess or you have a reason?
I just failed, sir.
There is no reason, right? There is no risk. What are the risk factors for ectopic pregnancy? Tell me. We are going out of the topic, but still useful, right? What are the risk factors for ectopic pregnancy?
Uterine abnormalities.
Uterine abnormality.
Intrauterine fibroid.
Okay.
Inflammatory disease.
Tubal ligation.
Okay, tubal disease. What else?
Previous ectopic pregnancy.
Previous ectopic pregnancy. Okay.
Use of
Tubal-
IUDs. Use of IUDs.
Yeah, insertion of IUDs. Pelvic inflammatory disease. Okay, any tubal damage. So most of the teenagers have a brand new uterus and tubes, no? And usually without infection, unless they are very promiscuous from early age, right? That is not very common, no? Okay. So they are not at high risk of ectopic pregnancy, okay? They will not have IUCDs inserted, fibroids and the endometriosis develop later, right? And we don't see much pelvic inflammatory disease in young girls unless they are very, very promiscuous and have multiple sexual partners, unprotected sex. So theoretically, we don't see, right? It's not high risk. Okay. Anything else? So the first trimester, those are the things we will see. Okay. Miscarriages, early first trimester bleeding. So they will need a scan. Okay. And there could be gestational trophoblastic tumor. Hyperemesis may be exaggerated because of the psychological vulnerability, psychological problems. And then second trimester, we'll move. Second trimester, the nutritional anemia and the nutritional problems will crop up usually in the second trimester. Okay. And the psychiatric or psychological problems also will be exaggerated in the second trimester. Anything else you can expect happening in the second trimester? What are the other risks?
Uteroplacental insufficiency and FGR.
Yes, uteroplacental insufficiency can cause fetal growth restriction. On the same line, what else because of that they can get?
Preterm labor. Preterm labor.
I couldn't hear.
Preterm labor.
Preterm labor, that is another one. No, you said uteroplacental insufficiency can lead
Pregnancy
to
induced. Pregnancy-induced hypertension.
Yes, pregnancy-induced hypertension, also of high risk in teenage pregnancy. Same pathology, right? Okay. What else?
Pregnancy-induced hypertension may lead to preeclampsia, eclampsia, and premature birth of the fetus.
It's not premature birth, preterm delivery, right? Okay. Usually, if they get preeclampsia, eclampsia, it is an iatrogenic delivery. Okay. So, leading to preterm delivery, usually by an emergency cesarean section. So, there is a risk of having to undergo emergency cesarean section and also risk of having a preterm delivery. With pregnancy-induced hypertension and preeclampsia, there is another risk also which can cause preterm delivery. What is that other risk? Related to pregnancy-induced hypertension and preeclampsia. They can get another complication which will warrant immediate or early delivery.
Placenta
Abruption.
Placenta?
Abruption.
Abruption.
Placental abruption. Okay, so that can happen. So they can lose the baby also if they neglect that. Okay, right? Placental abruption. So those are related to each other, right? Fetal growth restriction, pregnancy-induced hypertension, preeclampsia, eclampsia, and placental abruption. So they can have, sometimes they can have a death in utero or preterm delivery, and the baby could be in the special care baby unit. Okay. Now, somebody said preterm delivery, preterm labor. Is that high risk in teenage pregnancies? Preterm labor.
Because of nutritional problems and
Yeah, because of the whole
socioeconomic.
problem. Yeah, it is high risk. They can have preterm labor because of the poor socio-economic background, nutritional problem, and because of that lack of proper antenatal care. Everything can lead to preterm labor, right? Anything else? And in the second and third trimester, again, the psychiatric problems will be there, right? They may lose school education if they are going to school, right? And social dilemmas, right? Because of the social problem, they may have to take the child to some other environment, not in their village or hometown. So those are the possibilities, right? Anything else? Any other complications? Anybody? Antenatal complications or problems? So we have covered, yeah, most of the antenatal and complications we have covered, right? So to repeat them, first trimester, what did we say? The miscarriage risk is high. Gestational trophoblastic tumor risk is high. They can have hyperemesis, okay, and psychological or psychiatric problem. Second trimester, nutritional problem, nutritional anemia, fetal growth restriction, pregnancy-induced hypertension, and preeclampsia, placental abruption, and then another category is preterm labor. Okay. So those are the main antenatal problems we can expect in a teenage pregnancies. Now, next thing is the intrapartum problems. What are the intrapartum problems we can expect in a teenage pregnancy?
poor progression of the labor because the mother may not bear the pain and the pelvis is not adequate for.
Yes, she is not physically grown up. Her pelvis is not physically grown up as an adult, right? So there could be cephalopelvic or fetopelvic disproportions. So the pregnancy, the labor could be prolonged. Because of that prolonged labor, and there could be prolonged second stage as well. Okay. Because of that, what are the risks she could have?
Fetal distress.
What? Fetal distress.
Increased perinatal mortality.
Yeah, that will finally that will be the thing. But before that, what are the things can happen because of the prolonged labor and prolonged second stage? What are the immediate risks?
Increase the rate of cesarean section because of
there is a
teenage
higher
pregnancy.
chance that she could undergo emergency cesarean section. What else?
Instrumental deliveries.
Yeah, higher incidence of instrumental deliveries. What else?
Because of the instrumental delivery, there may be damage to the
higher incidence of trauma. Not only because of the instrumental delivery, even with the normal labor without instrumental delivery, since their pelvis is not adequately developed, there could be some restrictions, no? So because of that, they can have again trauma to the perineum, right? So trauma. So cesarean section, instrumental delivery, trauma. All three can lead to what?
postpartum hemorrhage.
Postpartum hemorrhage. So there is a high risk of she having postpartum hemorrhage. Okay. Right. And third degree or fourth degree perineal tears. Okay. Right. So because of that, there is a chance of higher chance of them dying. Increased maternal mortality, right? Compared to a grown-up adult. Okay. Right. Anything else? Any other problem we may face? Intrapartum. Yes, they have poor pain tolerance because they are not mentally prepared for this pregnancy. Most of them maybe for them it is an unwanted pregnancy, right? So they are not mentally prepared. They are not enjoying their pregnancy or delivery. So they will not tolerate the pain properly. So the pain tolerance is very, very poor. What else? Okay, we have covered the intrapartum problems associated with teenage pregnancies. Okay. So what are the postnatal problems we may face?
Feeding problem.
Feeding problems, because they are, again, it is an unwanted pregnancy in most cases, and they are not well educated and they are very young, so they may face feeding problems. Okay.
Postpartum psychosis.
Physical problems.
Postpartum psychosis.
Yeah, postpartum psychosis and depressions is, again, even if they have managed their antenatal period without any psychological or psychiatric problem, after delivery, right, when the newborn comes, again they are very prone to get depression, postpartum depression or psychosis. Okay, depending their psychological vulnerability, right? So that risk is there. What else?
Poor social support.
Hmm?
Poor social support.
Poor social support, that can lead to psychological problem, right? That is because of that only they have come to into this position, you know, because of their poor social support, right? Family support. Because of that only they had their teenage pregnancies, most probably, right? What else?
Poor bonding between the fetal baby and the mother.
Poor
Bonding between the baby and the mother.
providing.
Poor bond between the baby and the mother. The
Not clear.
relation.
Your answer is poor.
The poor bond between the mother and the baby.
Ah, yeah, poor bond. Yeah. Okay, that is again a psychological problem, right? Bonding between the mother and the baby, newborn baby. Okay, correct.
Increased risk of puerperal sepsis.
Yes, increased risk of puerperal sepsis. Again, they could have perineal trauma, and they are mostly from poor background, and they may not come to a tertiary care hospital for sometimes delivery. There could be home deliveries. Okay, so the risk of puerperal sepsis is high. Yeah. Anything else? Other thing is they may have to stay in the hospital, you know, for a longer period postpartum compared to a adult woman, because the baby may have other problems, or there could be early deliveries. So baby may be in the special care baby unit, or prone to infection or feeding problem. Because of that, their hospital stay may be longer, right? So these are the problems we could anticipate or face in teenage pregnancies. So a whole lot of problems are associated with teenage pregnancies. Now we'll move on to the management. Knowing what are the expected problems, we have to tailor-made the management of teenage pregnancies. Okay. So we'll go on to the management. And you can answer the management also. That is also we go by first trimester, second trimester, and third trimester. You don't need to mention first trimester, second trimester, but you go in that order, right? Okay, can anyone start with the management? There's routine management also. I don't want the routine antenatal care like any other women, pregnant women. Yeah, tell me.
As this is a high-risk pregnancy, it should be managed in the tertiary care hospital.
Yes, they should be registered in a tertiary care hospital, and there should be early booking, right? Okay, right. Okay. What else?
Then she should be given psychosocial support very well, and
Yes.
we.
So there should be a multidisciplinary approach in the management of a teenage pregnancy. Any psychological problem should be identified very early, and from the first trimester itself, even if she doesn't have any psychological problem, she should be referred to a psychiatrist or psychologist for a counseling or session, right? What else?
She also should receive routine antenatal care.
Yeah, routine antenatal care she should receive, but I want you to highlight the important aspects she should definitely receive, tailor-made for the teenage pregnancy. That is what you have to
she should be educated regarding the pregnancy and the way from the conception to the delivery.
Yeah, conception. Yeah, if she is not educated, education is very important. Okay. So usually regarding the pregnancy, the problems, how to continue the pregnancy, the nutrition during pregnancy, feeding, all those routine stuff, education is must. What else? Sometimes we may have to counsel her parents also, you know, to support her. They will also need support, the parents, right? They are also probably will be depressed or may not be helping their daughter. So we had to separately encounter the parents or any guardian and advise them to look after. So we have to educate them if they are not educated well regarding the pregnancies and the care plan, and we have to have their involvement at the maximum. What else?
As she is vulnerable for fetal growth restriction, we have to follow up with that by
It's the
using ultrasounds.
second trimester one. Shall we finish the first trimester problem, first trimester management? Folic acid is must, right? Okay, folic acid is must. What else is very essential in this teenage pregnancy, in the first trimester?
Dating scan.
Dating scan is very important because usually in the teenagers, the menstrual cycles may not be regular. And other thing is they may not remember their last menstrual period. It may be a rape or it may be anything, but they are not, they are not sure most probably about their last date. Because of those reasons, a dating scan is very important. And also, we may be doing an early delivery in some cases. They may go into preterm labor, or we may be delivering early because of conditions like preeclampsia or eclampsia. So we should know the exact gestational age for proper management. For that, an early dating scan is very, very important. Okay, what else? Anything else? So you had to counsel in the first trimester itself with their parents that about the importance of attending the antenatal clinic regularly and regarding the supplements and to attend other educational sessions. That is very important, and also arrange the meeting or the referral system to meet regularly the psychiatrist or the psychologist. And also we should contact the public health midwife of the area and tell her to look after this girl, and also we have to tell the parents and the girl to be in contact with the public health midwife of the area. Sometimes they may have changed the areas also because of social problems. In that case, also very important to notify the public health midwife to give special attention to this pregnancy. Now we'll move to the second trimester management.
I have a question.
Yeah.
Sir, if let's say it's a case of incest and
Yes.
the father is the rapist, and and the daughter is pregnant,
Yes.
what happens there? So do you separate them or what?
The father and the daughter.
Yes, sir.
Yes, of course. Probably they will be separated. The mother would have chased the father, right? So that should happen. In sometimes, the girl may be the mother may be working abroad. So in that case, we have to have a proper guardian. So for that, the public health midwife or other, the relative should be arranged to look after the girl, or she should be taken to the probation, right? So a lot of things we have to look into.
All right. Thank you.
And also in cases, but still we have been fighting for at least these incest and severe fetal anomalies to have termination of pregnancy legalized from the colleges, but that is pending, right? Okay.
Okay.
But in these type of cases, we get the psychiatrist opinion and the obstetrician opinion, and probably we arrange a termination in the hospital.
Okay.
Right. Anything else? Yeah, second trimester. Coming to the second trimester, what are the special things you have to?
Blood pressure and urine
Yeah,
protein
blood pressure and
estimation.
urine albumin should be checked regularly because they are at high risk of pregnancy-induced hypertension.
Pregnancy-induced hypertension.
Hypertension. What else?
Regular monitoring of the fetal growth because they are risk of
Yes.
fetal growth restriction.
So initially, every 4-weekly ultrasound scan for growth and like volume, the Doppler flow, to identify early the risk of fetal growth restriction and pregnancy-induced hypertension. What else? Nutritional advice should be given. She should be, educated, and the parents or guardians should be educated to give her proper diet. We cannot give everything with supplement, right? Supplements also should be given, but the diet also should be advised, to have good protein, vegetables, and the calcium in the diet, right? So dietary advice is very important. What else?
So psychological support again.
Psychological support should be continued. If she want to continue the education, that has to be arranged. If she want to continue the education, probably sometimes O-level examination or advanced level, right? So that should be arranged. Those are the cases that like victims, and when they want to school, and then we arrange termination based on that and other psychological problems, right? Anything else? So the weight gain should be monitored. Okay, weight gain is very important, right? Most of them are small made, so we have to monitor the weight gain during pregnancy. She should be advised on regularly attending the antenatal clinic. Then only we can do all these blood pressure measurements and the scans regularly. And also she should be warned about going into preterm labor. Okay, so we have to teach her about the signs and symptoms of preterm labor and advise them to come to the hospital as soon as possible, right? So if they come in preterm labor, pre-eclampsia, eclampsia, the management is not different from any other pregnant woman. So we are not going to discuss on that. Okay, so management is same for a 14 or 16-year-old with pre-eclampsia and also a 28-year-old woman with pre-eclampsia. Anything else?
Screening for sexual transmitted disease.
Yes, if it is, especially if it is a rape, or if it is, if she had multiple partners or incest, better to screen for all the sexually transmitted diseases. That we should be arranging at the beginning, at the booking visit, or even before they are usually referred after rape to us. Then we do the STD referral and screening. Anything else? So that is, most of the things we have covered. So the management should be tailor-made to suit her. So we have to address all the aspects of the pregnancy when it is a teenage pregnancy. Okay, the nutritional support, the psychological support, the social support, and the support from the public health midwives, and then our input from the tertiary care hospital. Then only we can minimize the problems associated with teenage pregnancies. So the management, how to minimize the intrapartum problems. Intrapartum problems, how to minimize.
Adequate pain relief. And during
Somebody has posted whether we should assess regularly the cervical length. The answer is no in a teenage pregnancy. Okay, we don't need to arrange a cervical length assessment adequately, regularly, right? That is done in a pregnant woman who had a previous preterm labor, or who have symptoms of preterm labor at present. Then only we do the cervical length screening. But in a teenage pregnancy, we don't do regular cervical length assessments. Any other questions? Somebody else also wanted to ask a question.
Sir, regarding the definition of teenage pregnancy, if there is a question, define the teenage pregnancy.
Yes.
Is that okay to?
Yeah, that's correct. So there is a question. There is a previous essay questions, no?
Yes.
So we have asked this question several times regarding the teenage pregnancy, right? So this is the answer I'm discussing, right? Okay, the lecture is the answer. So we start with the definition of the teenage pregnancy, right?
Yes.
And then management, no? Or we ask in different ways strategies to reduce the morbidity and mortality associated with teenage pregnancies. Okay. If the question is like that, also you have to define teenage pregnancy when you are answering the introduction, and then you have to define the problems, and then only you are discussing the strategies. So the same thing, right? Okay.
Sir, can't we say it that it's a pregnancy of less than 19 years, because 19 also belongs to teenage?
Yeah, but we take as 18 years, right, and below. 19, 20 is more like adults, right? Okay.
Thank you.
Yeah. Any other questions?
So when asked about the measures that we can do regarding to reduce the incidence of teenage pregnancy,
that is a different question. That is a different question. That is again, we will come to that question at the end, right?
Okay, sir.
Okay, because that is a general question, no? It is like a lot of things has to be discussed, right? Anything regarding to the pregnancy itself now, the incidence reduction is again a different question that is, right? Okay, intrapartum problems, how can we, what is the management, intrapartum management?
Giving adequate pain relief, because they have reduced pain tolerance, and that may lead to dysfunctional labor. So if we are
adequate pain relief should be there. Other thing what I have missed is the antenatal care should be a consultant led. Okay, give me a minute. Hello. Okay, all right. So the consultants or obstetricians input should be there from the beginning. Okay, and before we go into the intrapartum care, the mode of delivery and the timing of delivery should be assessed and decided by the consultant. Okay, so if there is gross cephalopelvic disproportion, the pelvis is not adequate and the baby is big, we may go for an elective cesarean section in a teenager like 13, 14, 15-year-old girl. But if she is 17 or 18 years, if the baby is well grown, we may try induction of labor, but with low threshold for cesarean section. If the baby is of average size and the pelvis is good, then only we wait for spontaneous onset of labor. But even with that, we would not like to wait beyond 40 weeks in a teenager, right? So by 40 weeks, we would try to induce a teenager. Okay. So coming to the intrapartum care, again, the consultant's input is very important in the intrapartum care. And as one of you said, pain relief is very important. So that should be because they cannot tolerate the pain properly. So we have to offer the pain relief from the beginning. So we have several modes of pain relief. So if we can give the epidural, that is all right, or the pethidine we can give. What else? Yes, very good. So labor companion should be encouraged. So we have to identify a labor companion from the beginning and groom her to be the labor companion for this teenager. What else?
As this is a high-risk pregnancy, continuous fetal monitoring during the labor, throughout the labor.
Yeah, continuous electronic fetal monitoring should be there. Continued. What else?
There is a high risk of postpartum hemorrhage. So inform the blood bank and have cross-matched blood.
Yes, we can cross-match if we think there is a risk of cesarean section. So we should have a low threshold for cesarean section. So in cases of poor progression, she should be assessed by a senior obstetrician or the senior registrar, and then the decision should be made whether to continue the labor or to plan for a cesarean section. So the decision should be made by a senior person. Otherwise, the inexperienced people can hang on to this pregnancy and she may end up with complications, right? What else? Yeah, and apart from the usual, the active management of the third stage is very important because there is risk of PPH, okay? And after delivery, especially the perineum should be inspected for perineal trauma, and it should be managed as soon as possible by an experienced person because she is a young girl, right? She may have a long-term problem if we didn't manage the perineal trauma properly, right? She just started her journey and she is young and she can have bladder problem, bowel problem, and sexual dyspareunia and sexual problems if we maltreat the perineal trauma or not identify any perineal trauma. So that is very important aspect, right? It cannot be sutured in the labor room. She should be taken to the theater and under anesthesia, it should be repaired properly by an experienced person. Okay. What else? So those are the important aspects of intrapartum care in a teenage pregnancy: the pain relief, the consultant input, continuous CTG monitoring, and the maintenance of partogram. Okay, and early decision making by an experienced person. The management of the third stage, right, and repair of any perineal trauma is very important. And postnatally, how do you manage postnatal? Again, we have to look for any psychological problem that may crop up newly during the postnatal period. She can harm the baby, right? So we had to be on vigilant for those kind of problems, and also look for bleeding. And she should be given adequate pain relief. Probably she would have had a cesarean section or instrumental delivery, or she would have had perineal trauma. So adequate pain relief postpartum is very important. And support for the breastfeeding should be also there from the staff. And if everything is all right, we can discharge. And what are the advices we should be giving on discharge?
Continuation of supplementation.
Supplement should be continued. Okay.
Contraception.
Contraception is very important. We should be offering her long-term contraception, right? What are those ideal ones in a teenager?
Implants.
Implants, yes.
DMPA.
Rather than DMPA, that can cause, you know, the irregular bleeding and problems in a teenager. We can go for IUCD, right?
IUCD.
Okay. IUCD, the implant is all right, but sometimes the DMPA give more trouble, right? Anybody ask a question? Anything else? After several weeks is ideal, okay? But if we are not sure about whether she will come back or not, depending on her social background, okay? Sometimes postpartum IUCD and postpartum the Jadelis should be used, right? Okay, especially if her parents are also not well educated, and if you can't rely about the parents, right? Then postpartum IUCD is okay, right? Immediate postpartum. So otherwise, if she is very reliable and if she is, you know, understandable and probably in those are the cases whether they have a regular partner, only thing they will be getting married in another 2 or 3 years, right? Or she want to continue her education, she is educated, this unfortunately she got pregnant, and those kind of girls will come back for the contraception, okay? The other category is the one who are vulnerable, you know, we will not come back. So those people may need postpartum IUCD inserted. And we have to explain about for them to have a good, you know, not to get pregnant till they become 19 or 20 years, right? Okay, to wait till they get mature, right? And then offer contraception. And also we may have to, you know, give other social support for her, because depending on the partner or whether there may not be a regular partner. So in those cases, she will need long-term follow-up by the social groups as well as from the midwife. Need follow-up, right? That should be arranged if she is vulnerable further, right? So she may contact any sexual transmitted diseases as well, right? And any support to continue, if she want to continue her education, that support should be arranged. Okay, that is the management of the teenage pregnancy. Any questions you want to ask or anything you want to contribute within that context?
Sir, if we are inserting IUCD right after the delivery, isn't it cause
Yes.
increase risk of sepsis or endometritis?
No, that is not the case. This is in practice actually, right? Postpartum IUD is established thing now, so we can insert it, right? But there is a risk of that can come down, right? Those are some of the risks are there, but it's not very high. But when they have this postpartum IUCD, there is a follow-up plan, right? From the MOH and the midwives. So she should adhere to that follow-up plan, right? So it is, it could be done. Anything else? So coming back to the question somebody asked earlier, how to prevent, what are the measures to be taken to prevent teenage pregnancies? That is a general question, right? Okay. So there we are not asking the management of teenage pregnancies. There we are asking about the measures to prevent teenage pregnancies. Understand? So that is, so you have to discuss all lot of things from education, availability of contraception, right? Sex education in schools, the political involvement, legalization of termination of pregnancies. Okay, so all aspect has to be covered. Making available the contraception, contraceptive knowledge, right? Yeah, that is a different question. Okay, so it's you can write, anybody can write answer for that question, right? Okay, it is general measures, right?
Yes.
So that is even changing all the structure of the country, you know, to alleviating the poverty, economic problems, educational problems. Okay, so all aspects you have to touch when you are discussing about preventive measures to minimize or reduce incidence of teenage pregnancy. But if the
Sir,
question is, yeah, yes.
when we are answering that question, do we have to follow that primordial preventive actions, primary
Yes,
preventive
yeah, yeah. Primary, secondary, everything. But incidence of teenage pregnancy here, okay? Incidence. So another question may be, what are the measures you can take to prevent the or reduce the morbidity and mortality associated with teenage pregnancy? In that case, the primary prevention, secondary prevention, tertiary prevention is very important, right? Okay, to reduce the incidence of morbidity and mortality associated with teenage pregnancy. So your plan will be more suitable for that question. To prevent incidence of teenage pregnancy, again, you can go in that line, but you have to touch all aspects, you know, and most of these aspects are primary prevention. Okay, so you don't have much secondary or tertiary prevention to reduce termination of pregnancy. That is secondary, seeking the medical advice when they are pregnant and offering termination, right? Okay, understand? Those are not much. So it is mainly the primary prevention. So you don't need to divide when you are discussing to reduce the incidence of teenage pregnancies. Okay.
Okay, sir. Thank you, sir.
Any questions? Any more questions?
Sir, another question not regarding the teenage pregnancy.
Okay.
During the antenatal period, exactly in first trimester, if we have identified that the fetus is having lethal complications.
Okay, it's an anomaly. Okay.
Yes. What should be the management? Can we terminate the pregnancy?
Lethal anomaly, it is still not legalized. The termination is not legalized in our country. So we cannot do anything unless it is the only reason we can terminate is the pregnancy is going to have to kill the woman, you know, the mortality 50% or more. If it is a psychiatric problem causing, right, then we can justify she is getting psychiatric problem and she can have suicidal attempt. On that line only we can justify, not because of a lethal anomaly.
Otherwise, we have to continue the pregnancy as a normal.
Yeah, we continue.
Normal way.
Yes. For one good example is anencephaly, right? We continue, right? Unless they go into preterm labor or miscarriage, right?
Do we
It's
have to give
unfortunate,
them?
yeah.
Do we have to give them special care or normal routine antenatal?
Normal or less than normal, but they may get other complications, not GDM or those pregnancy-induced hypertension. So we have to be looking into that. If they happen to develop those things from the, we don't need to wait for the fetal maturity. We can justify and terminate the pregnancy. Understand? Preterm delivery.
After that pregnancy, if the mother is waiting for another child, do we have to wait for about 2 years to have another child?
After an anomaly?
Yes, sir. After after
No
finishing
need of
that
2 years,
pregnancy.
just we allow her to recover physically as well as mentally. Unless if it is a cesarean section, better to wait for more than 1 year, right? But if it is a just normal, most of the time we have normal deliveries with the anomalous fetus, right? So maybe 6 months is enough. If she is physically and psychologically stable, she can go for the next pregnancy. And most of the women are willing to go for the next pregnancy quickly, hoping to have a good pregnancy. So that hope also we have to give.
Okay, sir. Thank you.
Okay, anything else? So I think we had a discussion, and for the next lecture, still I may be doing on grand multipara or elderly primate. Could you please explain about the progesterone withdrawal test? Progesterone? Who has asked that question? I didn't understand the question properly. It is not related to this topic as well. Okay. Anything else? Okay, we will, yeah, you have a few more lectures lined up for you all this week and next week. And I will come in probably the next week. We'll arrange. Okay. The next topic I may be discussing is probably the advanced maternal age, pregnancy with an advanced maternal age. So opposite of the teenage pregnancy. Today we discuss about the pregnancy with teenager, and the next time we are going to discuss the opposite of that, pregnancy in an advanced maternal age woman. So 35 years and more. Okay. Thank you for listening, right?
Thank you, sir.
Okay.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.